My case presentation is over a client we'll call BD. She's a 65 to 75-year-old female. She has no history of drug or alcohol abuse, a non smoker. She lived with a friend, however, she was a poor historian and we had no family to gather further information. Patient had a fall and presented to the hospital with a left femur fracture. Status post surgery, patient was sent to Signature for rehabilitation purposes. Patient had a history of dementia and had acute post-operative delirium, and patient sent to Signature for rehabilitation. Our clinical evaluation was that the client had severe cognitive impairment with possible receptive expressive language impairment. Patient was confused and disoriented. She was assessed by all rehabilitation professionals, occupational therapy, physical therapy, and speech therapy. Patient was picked up by all three. Her medical history consisted of dementia with postoperative delirium, high cholesterol, diabetes, asthma, depression, osteoporosis, GERD, obstructive sleep apnea, and breast cancer, status post lumpectomy. Patient was receiving multiple medications for known illnesses and pain inhibitors for pain related to surgery. However, the pain medication provided is not strong enough and patient continues to be in a great deal of pain. Doctors and staff were notified several times. Limitations included weight-bearing precautions due to surgical procedure and she has become a fall risk due to confusion. Her social history, the patient had no family or community support that we know of, and she was a poor historian and we had no one to contact. Patient was referred for speech evaluation due to the dementia diagnosis and the acute onset of delirium postoperatively. Our initial clinical judgment included expressive and receptive language and cognitive deficits. Patient tested using the neurobehavioral status exam, standardized by Signature Healthcare. The NBSD evaluation scores included orientation of 10%, immediate memory of 10%, short-term memory of 30%, long-term memory of 10%, simple verbal reasoning of 10%, abstract reasoning 0%, problem solving 30%, with an overall score of 14.2, showing that she had a severe cognitive deficit. Our goals initially were established for short term of auditory comprehension, orientation with visual and verbal cues, functional problem solving, and memory, in order to facilitate patients' participation in ADLs and facilitate return to least restrictive environment. Long-term goals was to improve the patient's overall NBSE score in order to facilitate return to the least restrictive environment. However, patient decline in health and verbal expression goals were included in her plan of care. Another long-term goal was that the patient wanted to return to her previous level of care. However, it was later noted that she would remain in long-term care due to deficits. Therapy included using visual and verbal cues to facilitate accuracy. A calendar was used for orientation to date and time, and spatial retrieval therapy was used to improve memory. Patients' goals were scaffolded from simple to more complex to improve accuracy. Verbal expression started with concrete items. Patient would attempt to work with speech therapy on most occasions, however, many times would refuse due to pain. Patient was medically fragile and health was inconsistent. Therefore, her progress went along with her health. The patient arrived with severe deficits and moved up with visual and verbal cues to moderate deficits. However, patient's progress was inconsistent with all goals, ranging in from 30 to 40% up to 70 to 80% accuracy. Patient did not meet any goals while I worked with her. And before leaving, the patient was fully bedridden with maximal assist, along with inability to communicate with nursing or other staff. What I learned during this experience with this patient is that even with the proper therapy treatments, a patient's progress may depend on their health and ability to physically function. I don't believe that there is anything we could have done differently for this patient. Her health was just too inconsistent. In other cases, I feel that we should be followed more closely by a neurologist. Any questions?